Asthma in children. The childhood asthma present unique diagnostic challenge as children under 5 years cannot reliably perform spirometry. Diagnosis typically relies on symptom patterns, family history, and therapeutic trial with bronchodilators. So wheezing, persistent cough, especially at night, and excessive and exercise intolerance are key clinical indicators. Additionally, recurrent respiratory infection, difficulty feeding in infant, and audible chest sound without a stethoscope can signal potential asthma. The Asthma Predictive Index API helps identify children at risk for persistent asthma based on frequency of wheezing episodes combined with specific risk factors. Age appropriate inhalers devices are essential for effective treatment. So infants and young children benefit from spacers with masks, while older children can use standard spacer. Parents must be trained in proper technique of inhaler to ensure medication reaches the airway. Low dose inhaled corticosteroid remain the preferred controller medication for children of all ages. Common error in administration include improper mask seal, inadequate breath hold, and poor coordination between actuation and inhalation. Regular technique reassessment at every clinical visit improves medication efficacy and reduce its side effect. Regular growth monitoring is crucial as high dose inhaled corticosteroid may temporarily affect growth velocity, which is zero point 0.5 to 1 centimeter per year. However, poorly controlled asthma itself can impact growth more significantly. Children should remain or maintain age appropriate physical activity with proper pre-exercise medication when needed. Height should be measured every 3 to 6 months and plotted on a standard growth chart. Current evidence suggests that children eventually reach their predicted adult height despite temporary growth effects, especially when using lowest effective dose of controller medication like corticosteroid. Treatment approach differ by age group. For infant and preschool, that is 0 to 4 years, intermittent therapy with as needed bronchodilator may be sufficient for mild infrequent symptoms. School-aged children, that is 5 to 11 years, often require daily controller therapy with regular monitoring of lung function when able to perform reliable spirometry. Adolescent, that is 12 to 18, face unique challenges including decreased adherence and risk-taking behavior that may impact asthma control. Transiting care from parent managed to self-managed require structured education and a gradual responsibility shift. The psychosocial impact of childhood asthma warrants attention. Children with asthma may experience higher rate of anxiety, sleep disturbances, and school absenteeism. Family-centered care that addresses both medical and psychological aspect improves outcome. School-based intervention, including education of teachers and staffs about asthma action plans, ensure children receive appropriate support throughout the day, encouraging normal participation in sport and activities while providing safety measures help maintain self-esteem and social development. Support groups for both children and parents can reduce feeling of isolation and improve coping strategy. Thank you.